Our speaker today is Dr. Devin Oller, who's spoken for KY Open previously. He is a primary care and addiction medicine physician and served as one of the first rural health leadership fellows at the chief resident at Massachusetts General Hospital before coming to UK. He is an associate program director for the University of Kentucky Internal Medicine Residency Program and is an investigator for the NIH-funded Healing Community Study. Welcome back, Dr. Oller.
So I don't have any financial disclosures. Some things that we're going to try to cover today. So we know that access to medications for disorder is limited in part due to some knowledge gaps among providers about treatment options, and that includes extended release naltrexone. We know that if we increase that understanding among providers and patients about the risks and benefits of extended release naltrexone, we can do better by them, and that we might be able to have a better understanding at the health systems level, the significant costs associated with this medication in comparison to other medication. I hope today that you come away with a sense of the mechanism of naltrexone, how it works, why it works, and a little bit about its efficacy. But even more than that, I hope that you come away with some talking points, things to share with the patients, the clients that you see, or community members that maybe have some misconceptions about what naltrexone is, what it does, and its efficacy in treating opioid use disorder. We'll also review some barriers to extended release naltrexone initiation, why that initial period is so difficult, and some potential practical solutions to address those barriers. And my outcome is that I expect that you all take this away and use this knowledge to provide patient-centered information to clients and patients. So when I started preparing this talk on extended release naltrexone, I realized that I have a somewhat limited perspective and a biased perspective. And so it was important for me to ground this conversation in patient perspectives and other provider perspectives to make sure that all voices are heard when we think about this potential. So here are some patient perspectives, starting with some of the positives of extended release naltrexone. And I'll use the brand name in this quote, but I'll try to keep to just calling it extended release naltrexone. So one client said, I kept saying Vivitrol because I didn't want to take something every day again. And I think that's an important point, right? There's behaviors related to addiction where people feel trapped in the ritual of waking up and feeling the need that they have to take something. And in some ways, extended release naltrexone for this client in particular felt like a liberation. Another client said, once a month was good, not having like, I got to go there every day and take it. So speaking to some of the barriers to treatment for, say, methadone or buprenorphine, specifically having to get to and from clinic on a regular basis can represent a huge barrier, especially for our clients who are coming from rural communities or have significant transportation issues. Several mentioned that the blockade, basically how the naltrexone works on those opioid receptors, was a major positive. So one said, in your mind, you already know you can't get high, so you're not going to waste your time doing it, right? And we'll review this particular impact on cravings and urges and why naltrexone can be effective a little bit later. But I think the other important point here is that naltrexone is very selective for the opioid receptor. We know that it's potentially helpful for alcohol use disorder, but I'm going to focus specifically on opioid use disorder. It's less effective for other sedatives, things like Klonopin, Xanax, benzos, gabapentin, things that can still, quote, have a head rush associated with it. But it is certainly blocking the opioids. there's no withdrawal after starting, right? So with both methadone and buprenorphine, a point that I've emphasized in prior talks is that the dependence, right, the physical tolerance that develops on those medications is protective. It means that it's more difficult for somebody to have an overdose because their body is used to that level of opioid activation. But the drawback of that is if or when a client wants to stop or reduce the amount of buprenorphine or methadone that they're on, they are likely to face some withdrawal. And so for clients who really fear that withdrawal and whether that might trigger a return or a slip to a return to use or a slip, the extended release naltrexone represents a positive option for them. So patient perspectives, and this is from the same qualitative study that explores some negatives to extended release naltrexone. So 3 main categories: fear of overdose, blockade of pain medications, and some ambivalence about abstinence, right? So in terms of fear of overdose, one client said, you detox, you go upstairs, and then you go down with the Vivitrol, and you know the system's not what it was, so you take a chance, you know, you might kill yourself, you know. And so I think this is a really critical issue, and we'll come back to it several times in our talk today. But there is fear of increased risk of overdose because the patient has lost that protective tolerance over the time that they're on the extended release naltrexone. People are aware of that. They need to be more aware of it, but they acknowledge that that's a potential negative here. There's fear about, you know, if they're in a car accident or they have to get surgery, what is control of their pain going to look like? And this is often coming from the context of, you know, having stigmatized views directed towards them about pain. You know, if I ask for pain medication, are they going to just think that I'm, quote, drug seeking, right? And so we have to acknowledge this fear that, you know, if somebody is on extended release naltrexone, it might be more difficult. It will be more difficult to control their pain, and we have to have a clear plan in place for addressing that. Ambivalence about abstinence, right? So this gets to some of the motivational interviewing skills that you're going to need to have with clients to understand what's their motivation to get started on the medication, and making clear that you know, this is not a harm reduction tool. Naltrexone is not a harm reduction tool when it comes to opioid use. So they have to have complete cessation for us to even start that medication. And so if there is some ambivalence about abstinence, we really need to explore that and understand the reasons behind it. And these are some illustrative quotes of that ambivalence for clients who are starting naltrexone. There's some more negatives that they mentioned. So certainly going through the initial withdrawal, the majority of participants in one study reported some symptoms of withdrawal, ranging from it didn't make me sick, my body started acting up, to the worst withdrawals ever, trying to get through that period where the opioids are washing out of their system and they're able to start naltrexone. I love this quote about costs. It's like, what, $1,000 or $2,000, which is actually close to the specific price of the naltrexone. If you don't have insurance, yeah, so that seems like effing impossible, right? So the cost can be a significant barrier for people who are underinsured or uninsured, and we need to be open about that. Some mention sort of this false confidence, right? So going into treatment with naltrexone, and then on reflection back, you know, when they stopped naltrexone and they had a slip or a return to use, they were like, you know, I was feeling really good on naltrexone, but you know, I think I might have been overly confident about how I would be able to do during that time and after I stopped it. So making sure that we're aware of that. Oftentimes, extended release naltrexone, because of the difficulty getting through withdrawal, is initiated in controlled settings. So a residential addiction treatment program, an inpatient hospital stay. And there's a lot of support. There's a lot of touch points with providers, with peer supports, others in that period. And so some of that feeling good about their recovery can come about because of the setting that they were in and not necessarily because of the medication. And so we just need to be aware and open about this particular drawback. And then a separate qualitative study asks providers, so doctors, APPs, about their perspectives on naltrexone. A few people actually mentioned the challenge of starting them on naltrexone. So many patients, said one doc, are lost during those 7 or so days where the opioids are washing out. And the actual act of getting them started and through that withdrawal period was fairly time intensive. Others, overlapping with patients, were concerned about costs. And with one saying, if it isn't covered, 95% of people I see don't want it. And then the concerns about long-term efficacy, which we'll get to a little bit later. It's going to get you sober for 1 month, said one doctor, but after that, it's the 2nd month and the 3rd month, and those sort of shots that you really need moving forward. And that speaks to the challenges of keeping folks in treatment when on naltrexone, which we'll also address. So those are some perspectives that I think are important to start with, because a lot of what I'm going to review after this is the data, the studies, the evidence behind naltrexone, its pros and cons. But the questions that I'm trying to answer for you all are driven by these patient and provider perspectives. So how does naltrexone work? Let's break it down into a couple of pieces. So the easiest way, I think, to explain it to patients is to compare it to the other treatments for opioid use disorder that we have and know are effective. So I love sort of the plug metaphor here. So methadone is like a regular plug that fully activates that opioid receptor. Buprenorphine is like a plug into a power strip. So it partially activates the receptor and is potentially a little bit more safer than a plug straight into the socket. And because both buprenorphine and methadone are plugging into that socket, they are activating the opioid receptors, which means that they can treat withdrawal, they can treat cravings, they can treat pain. The naltrexone is like those plastic plugs that we put into the receptor so that we can't inadvertently put in another charge there. And so it blocks that receptor without actually activating it. So it's not going to help out with withdrawal. It's not going to help with pain. We'll get to why it might help a little bit with cravings, but it gets at that through a different mechanism. So it is sitting on that receptor and binding to the mu-opioid receptor and blocking other opioid agonists from reaching the receptor and activating them. So it doesn't treat withdrawal. It does not cause withdrawal when stopped, but it's not activating that receptor, and that's why. So one question that patients often ask me is like, hey, aren't there things in our like natural opioids in our body, like these endorphins things that make us feel good? What happens to them? Does naltrexone block those as well? So it's important to share with clients or patients that there are other opioid receptors, not just the mu-opioid receptors, in the brain and the spinal cord, and those natural endorphins are binding there and providing some of those same symptoms, symptom relief in terms of mood and sleep and those sort of things. But it's important to just emphasize that. So again, a comparison: you have methadone fully plugging into that socket, providing that activation of the opioid receptor. You have buprenorphine, which partially activates, like that surge protector, and then naltrexone, which is just sitting there and the plug and out competing the other opioids that are trying to. The other thing to mention when we talk about sort of its mechanism of action is it, because its primary purpose is to sit on that receptor and outcompete other opioids that are into the system, you really need to make sure that you're saturating those receptors so that there aren't opioids sneaking in and activating them. And so the problem becomes with injection on a monthly basis, you get pretty good concentrations of naltrexone, that active ingredient in the Vivitrol, within the first couple of days. And then you see sort of over time, that level begins to drop off. And so by the time you're out to day 25 or day 26 or day 27, right before they're about to be due for their next shot, you're beginning to get some drop off of those naltrexone molecules off of the opioid receptor. And that's where we start running into issues, because as somebody is beginning to use again, more of those receptors are now open and can be activated by the opioid, and they're at increased risk for an overdose as a result of that. So that's the sort of purple blue line. It will come back to oral naltrexone, but just to show it briefly here, that's sort of the up and down spikes there that you see, where you get some protection as within a few hours after taking it, but over the course of even a day, that level is beginning to drop off below the level where it would necessarily saturate all those opioid receptors. This is a little bit of a confusing slide, but this gets to a little bit of how naltrexone impacts opioid cravings in a way that's different than how buprenorphine or methadone impacts opioid cravings. So this was a study in Russia. You see each one of the blue dots on the graph is one person. And each time there's sort of a little green X, that is a positive urine drug screen for an opioid. And so the top part of the graph is the placebo. So they gave them these placebo injections. And you see that, fairly quickly, you see a drop off in terms of the total number of blue dots, so the people staying in treatment. And you see relatively the same amount of those positive sort of green urine drug screens throughout the time that they're in this study. Okay, so people are continuing to use some opioids. They're getting some benefit from the opioid because the placebo is not really blocking the receptors, and so they get that positive reinforcement from the opioid. Contrast that with the extended release naltrexone on the bottom part of the screen. So as you are moving forward from the top to the bottom of the graph, 0 to 24 weeks into the study, you see some people are continuing to use opioids on top of the naltrexone, but you see less of that as the time goes on. You have one sort of outlier who's continuing to use throughout. But for the most part, after trying to use opioids the first time or the second time and not seeing that benefit, not seeing any positives to that use, that craving, that urge is somewhat extinguished, right? And in the same way of, if you went to fill up your coffee cup and somebody put decaf coffee in there, and you didn't get any impact on that time, or the next time you'd probably stop reaching for that coffee cup. So it's sort of the same way here. They're not getting an effect from that opioid, so that sort of craving, that drive to use, is slowly extinguished. But the concerning thing here, and this is a sneak peek at sort of a main concern for naltrexone, is that yes, that occurs. If they try in the first week or they try in the second week after they've released naltrexone, they tend to not try again. But as you get to that third or fourth week out from the shot, there's a little bit more trial of, hey, this is probably fading a little bit in my system. Let me just see if there's still a blockade on board. And you can see why that's dangerous, right? Because somebody has lost their tolerance to that opioid, and so that they're at increased risk for an overdose at that time. So before I go into the efficacy data, any other questions about how the naltrexone works, or that question about sort of the extinguishing effect of that drive, that craving to use? So let's talk about efficacy and naltrexone. Does this work? So the first question, and I want to just get this out of the way at the front and spend the bulk of the time talking about the extended release or monthly shot version of naltrexone. So the first question is oral naltrexone effective for opioid use disorder? And our answer needs to be a clear no, okay? Using the pill form of naltrexone can sometimes be helpful on top of the extended release naltrexone, especially towards that end of the month. But in studies that have looked at, taking this pill compared to a placebo, so a sugar pill, showed that naltrexone did not perform better in terms of keeping people in treatment and maintaining abstinence. In fact, when you combine those two outcomes, maintaining abstinence and retaining retention and treatment, it was actually worse than nothing, or the placebo, right? So we do not use oral naltrexone except when we're towards that tail end of the month with the extended release naltrexone, because it is not effective for the treatment of opioid use disorder. Question 2, when we compare extended release naltrexone to buprenorphine and methadone, which have been around for a while now, do we see a difference in terms of overdoses and keeping people out of the emergency room or the hospital, which are really important things, right? We want to make sure that people are living their life, that we're making sure that we're keeping them alive, out of the hospital. Right? So this is a little bit of a confusing graph. Let's focus on the left side of the screen first. So this is, when you follow people out and they receive this medication, either naltrexone, buprenorphine, whether they get an intensive outpatient program, they go through an inpatient detox program, and then you follow them out at 90 days, 180 days, 270 days, a full year. Do you see a difference in terms of somebody getting naltrexone and somebody getting buprenorphine or methadone? Buprenorphine and methadone is sort of this like tanny brown color. It's the line at the very top of this graph. And what that says is that the probability of continuing to live and thrive and not having an opioid overdose is highest for people who are on buprenorphine and methadone. And then you see sort of all these squiggly lines lower down on there, right? Which suggests that outpatient behavioral health, inpatient detox, naltrexone, intensive outpatient treatment, there's not too much of a difference in terms of how effective they are at reducing opioid overdose deaths. And all of those are not as good as buprenorphine and methadone in preventing an opioid overdose at 3 months. Okay, so that's lesson number 1. Lesson number 2, do these treatments keep people out of the hospital? And if they do, is one sort of better than the other? And again, you see that buprenorphine and methadone line near the top. It overlaps a little bit with the behavioral health outpatient component, but the rest of the lines, including extended release naltrexone, are down and not as good in terms of keeping people out of the hospital at 90 days compared to buprenorphine and methadone. But what about retention? What about just keeping people in treatment, right? Because if we keep people in treatment, we can better, link them to behavioral health support. We can help work with them to find a job. We can make sure that their other medical issues like hepatitis C are treated. What about keeping people in treatment? How does naltrexone do? So this was a small study. It was in Norway, and it compared sublingual buprenorphine to extended release naltrexone, and it followed people out for 12 weeks, so 3 months, to see how they did. And they found that in this small study that extended release naltrexone was not inferior, which is a double negative, but it was not inferior to buprenorphine for keeping people in treatment at 12 weeks. But there are so many limitations to the study. So number one, it was short. It was only that 3-month period, right? Number two, and this is really important, all patients in this study were coming from a controlled setting. So an inpatient detox, prison, other detox programs where that withdrawal period was being navigated with a lot of support and a lot of help, right? So this doesn't capture the population that we often see, that I see in my clinic, right? Where they're showing up and they're saying, I need help now, I used earlier today, right? This is a different population, right? The average buprenorphine dose was 11 milligrams. That's often lower and potentially underdosing some folks who were in the study. And there were more adverse effects in the extended release naltrexone group. So over half of folks who got extended release naltrexone reported a significant adverse effect. And that can be nausea, that can be worsening mood symptoms. So yes, in this small study where you took people who were in a very controlled setting and gave them extended release naltrexone and followed them for 3 months, they did okay. But I can't say for certain that this actually represents real life and what we see here in Kentucky with a lot of our clients. And so when we look at real world data, and this is from a couple of our state databases, as well as some of the preliminary data that we're getting from the Healing Community Study, we see that buprenorphine and methadone do better than naltrexone and keep people in care at that 180 days. So 64% buprenorphine patients, 74% methadone patients, but only 10% of naltrexone patients are staying in care at that 6-month mark. And the main risk there, and why that is such a concern that there's a difference there in retention, is when you stop naltrexone, there's a much higher risk of overdose. So this was a study that looked at people who were on extended release naltrexone, on oral naltrexone, on buprenorphine, recently stopped on extended release naltrexone, recently stopped on oral naltrexone, and recently stopped on buprenorphine, or just off treatment for 4 weeks. And they said, compared to somebody who was continuing to receive that medication, what does the overdose risk look like? So these are pretty stark numbers. So somebody who recently discontinued extended release naltrexone, and focusing on that because, again, oral naltrexone I do not think is an effective medication for opioid use disorder. Those recently stopped on extended release naltrexone have between 7.5 and around 17.7 per 100 person year increased risk of overdose, and that's fairly significant, and that's much higher than someone who is on buprenorphine or recently stopped on buprenorphine as well. So a couple of questions. So Lisa, great question. So are there any studies regarding retention longer than 180 days? What is the retention rate among 3 medications in the 3 to 5 year range? So that's a great question. I know of a couple of studies, specifically buprenorphine studies that have gone out to 5 years and show decent retention in treatment. I don't have the exact numbers for you. There are not similar studies in terms of extended release naltrexone that I'm aware of for that. What do you do to encourage individuals to stay? So Amy, great question. Can we save that for a little bit later, because I have a whole section on that. Awesome. All right, question 4, when it comes to efficacy and how does and whether naltrexone works. So what about are folks who are justice involved, who are recently coming from prison, who are maybe still incarcerated. So there was a study a couple of years back now in the New England Journal that looked at patients who were incarcerated and then released, and they received either extended release naltrexone or usual care, and they were followed over 24 weeks for the primary outcome of time to relapse, and as well as out to a year, okay? And at 24 weeks, the patients who were receiving naltrexone versus usual care, and again, usual care was not buprenorphine, it was not methadone, it was counseling, it was linkage to community services. You had a lower rate of relapse, 43% versus 64%. 43% is not a low rate of relapse, though, right? That is an extremely high rate of relapse, and one that is especially dangerous when we know that folks who are relapsing after being on naltrexone have that higher rate of overdose. And furthermore, the study found that at a year, there was no difference in terms of relapse rates from those who received extended release naltrexone in the study and those who had usual care. Is extended release naltrexone more cost effective than buprenorphine, right? So you can think, and this is a logical thought, I'm only seeing the patient once a month, so there's going to be less clinic costs associated with it. I'm only giving them this medication once a month. That seems like there might be some savings there. And if we're continuing them on treatment, there's a decent chance that they have some reduction in cravings and maybe a reduction in return to use. So maybe there's some cost benefits there. But when you can compare extended release naltrexone to buprenorphine, so sublingual buprenorphine, this was done before extended release buprenorphine was on the market. Over about a half a year mark, so 6-month period, we saw that extended release naltrexone costs an average of $5,000 more than buprenorphine. And that cost was driven a lot by the cost of initiation, so actually starting the medication. So the need for somebody going in for a detox or for inpatient hospital stay, the need for other medications to get them through that period of withdrawal, the potential hospitalization for overdose during that period when they've begun to lose some tolerance. So when you factor in all those things, there's actually a cost benefit to buprenorphine over extended release naltrexone. We'll reserve some time at the end for questions, but let's go ahead and jump into what it looks like to start extended release naltrexone, right? This is often the biggest hump to overcome in getting folks this treatment. Okay, so these are the can't miss issues, right? You can't use naltrexone if somebody is on pain treatment with opioid analgesics or tramadol or other opioids. You can't use naltrexone if they've developed physiological opioid dependence, and that includes for folks who are on buprenorphine or methadone. There has to be that washout period. If there's active opioid withdrawal going on, then we can't use naltrexone yet. We have to, again, allow that withdrawal to subside. If there's severe hepatic impairment, then we need to avoid naltrexone. But that also means, in terms of the stepwise approach that a client would have to go through, is that they would need to get some sort of blood draw, right, to see where that liver function is, often before starting the naltrexone for safety. So if they are concerned about getting blood draws, that would be something to bring up with them. We'll talk about the naloxone or naltrexone challenge, but if that is positive, then we don't proceed with extended release naltrexone. If a urine drug screen is actively positive for the opioid medications, then we often are not proceeding with extended release naltrexone. And of course, if they have any allergies to specific components of the shot. So those are the can't miss. These are the things that we should have some caution about. So certainly reactions at the site of giving the injection, which is often on the gluteal muscles, there can be some reactions there. The risk of overdose, if the patient discontinues treatment or misses a dose or attempts to override, especially in those last couple days or week, we can't underscore this enough. That is a really vulnerable period, and we need to be providing them as much help and support to get them in and get those subsequent doses. It's not considered appropriate right now for pregnant patients. It has been associated with hepatitis. So inflammation of the liver. I don't mean increased risk for hepatitis C or hepatitis B, which again are passed usually through needle sharing or sex. We have to monitor for increasing mood changes as well after starting the medication. And as discussed in those patient perspectives, those quotes, there's always the concern about what are we going to do when we need emergency pain control. And often that's using non-opioid medications to try to acutely control their pain. So this is my approach when I have somebody coming in, their urine is positive or they're actively experiencing opioid withdrawal and they're interested in naltrexone. I think about who, what, when, where, and why in terms of our withdrawal. So the who are, who are you going to reach out to if you're struggling? Who's going to reverse an overdose if you do have a slip or return to use as you're navigating this prolonged period of withdrawal? Again, for most, that's 7 to 10 days since last use before starting extended release naltrexone. What? So what medications are we going to use to help reduce your symptoms? What has been tried before to help get you through withdrawal? What's worked, what's not worked? When is now really the best time to navigate withdrawal? When should we target starting extended release naltrexone? Yes, we definitely need to have those safeguards of making sure that there's nothing in your urine, making sure that you're out of withdrawal. But maybe they've had experience where they started at 7 days and had more side effects versus waiting a full 10 days. And we just need to be able to review those risks and benefits in terms of timing with patients. Where? So can we actually do this in an outpatient setting, or do we need a little bit more higher level of care, more touch points, more checking in, more options to help folks get through withdrawal? And why, right? We can't lose track of what the motivation is for attempting to stop use right now. We talked earlier about that patient perspective of I felt a little bit coerced into treatment. I was still ambivalent about whether I wanted to stop use. And that can be a recipe for disaster as soon as that sort of societal or outside motivation to be on naltrexone stops, and they're just left with their own motivations, which might not be enough to say, I'm going to continue taking the extended release naltrexone. So who, what, when, where, why? Make sure that we're asking these questions as we're going through. Let me dive into a little bit more detail about each of these to give you a little bit more perspective and knowledge that you can share with. So this was actually a study out of UK. And really what it was looking at was, how long is that withdrawal period for somebody who is using opioids on a regular basis. And when you adjust how long you're providing a taper with buprenorphine specifically here, how does the length of withdrawal symptoms, the severity of withdrawal symptoms change depending on that taper? And so they compared a 1-week taper with buprenorphine. So a modest dose of buprenorphine the first day of 8 milligrams, and then stepping that down over the course of a week until they were completely stopped. A 2-week taper and a 4-week taper. And they saw that the severity of withdrawal was significantly a little bit higher especially in the first several weeks for individuals who underwent the 1 week taper compared to the 2 week taper and 4 week taper. But there was a little bit less of a difference between the 2 week taper and 4 week taper in terms of overall severity rating. So that's lesson number one. But lesson number two is notice how long they followed patients out. So they really followed them out to 5 weeks. And they saw that some still had, while modest or mild, still had some withdrawal symptoms that far out. And often those are mood withdrawal symptoms, so difficulty sleeping, more anxiety, those sort of things, but those are still real and still impacting folks. So the point being is oftentimes we are starting extended release naltrexone when the bulk of withdrawal symptoms have resolved, but some might still be present and still something that we'll need to try to help folks manage as they're starting their extended release naltrexone. When we talk about the what, in terms of what is going to help them get through withdrawal, so buprenorphine is often highly effective at relieving withdrawal. But the problem is, as soon as you're still going to need that period of time where you're off of the buprenorphine as well, right? And for some, they sort of look at weighing the risks and benefits and say, I'd rather be able to start the extended release naltrexone earlier than having to wait another week, another 10 days after that. There's a newer agent called lofexidine. It's an alpha-2 adrenergic agonist. It is the only medication approved by the FDA specifically for opioid withdrawal syndrome, or OWS. However, it's not all that effective and is very expensive. So more than half of the patients with opioid withdrawal syndrome who were treated with this medication dropped out of the study at day 5, right? And that just speaks to how withdrawal is certainly prolonged and can be fairly pronounced in the age of more and more fentanyl being in patients' systems and being in their systems for a while. Short-acting opioids in a patient setting, highly effective at relieving opioid withdrawal symptoms, but this isn't really an option as an outpatient for somebody with opioid use disorder to prescribe, oxycodone or Dilaudid or anything like that. We can't do it. So our approach is instead focused on symptom management. So for nausea, we might give something like ondansetron. For stomach cramps, something like dicyclamine. Muscle aches, ibuprofen. Anxiety or tremulousness, we might give some clonidine. So these are imperfect treatments. And again, if we're giving either full agonists in the hospital or buprenorphine in the outpatient setting to help get them through the worst of withdrawal, we're still going to have to wait that full 7+ days after their last dose of that agent before we can start extended release naltrexone. There's been a couple of studies published to try to speed up that process, often by doing a microreduction, so small doses of oral naltrexone. The fact of the matter is that this is not by any means ready for prime time. This particular study used a strong benzodiazepine called clonazepam to help people through withdrawal in combination with clonidine and trazodone, which can be really, really sedating for patients and has its own risk if somebody is returning to use in combination with the opioid and that clonazepam. This other study was not well designed, so they basically had somebody do a taper of buprenorphine or use buprenorphine just for 1 day and then switch to lower dose naltrexone. But here's the thing, at day 7, while they're at up to 25 milligrams of naltrexone, they're still getting buprenorphine, and then they have this washout period of another 7 days before they're getting naltrexone. So it's not a true comparison of over the course of a week, which is necessarily better in getting people onto naltrexone. And then the other thing to think about in terms of improving safety and the patient experience, minimizing their risk of precipitating withdrawal, right? Because the whole reason we try to wait before giving that first dose of naltrexone is that if there's opioids still on board and we give that naltrexone, the precipitated withdrawal is going to be very severe and very hard to get a control of. So a test dose is this idea of, hey, can we give a smaller amount to make sure they don't go into withdrawal before we give the extended release naltrexone. So the pros of this, and it's basically giving that small dose, 25 milligrams of naltrexone, waiting 60 to 90 minutes and measuring the COW score. The pros of this is that you're going to reduce that risk of precipitated withdrawal. And with the increasing prevalence of fentanyl, there's an increased risk of precipitated withdrawal. So that certainly can be helpful. The major con, though, is time. This takes time. Not only do you have to keep them in the clinic or in wherever you're practicing for that 60 to 90 minutes after the dose, and that's it before you even potentially give the extended release naltrexone. If you don't have that medication on hand, then you're having the patient leave, go to the pharmacy, pick it up, come back, and a lot can go wrong there. And they may abandon this plan to try to get on extended release naltrexone because of those additional hoops that they might have to jump through. At this point, I'm going to pause talking because I've been talking for almost an hour, and we're going to watch a quick video on what administering the extended release naltrexone looks like. And I think this is really helpful to share with our clients to just know this is going to be what a shot looks like.
So today we'll be showing the preparation and injection of the Vivitrol injection. So we have a box from the pharmacy with the kit, and in the box there is a vial with the macrospheres. There is a vial with a diluent. There is a set of needles. There are two 2-inch long needles for people with a large body habitus, and there is a set of 2 1.5-inch needles for the people with a regular or small frame. And there is a syringe to prepare the medication, and there is a needle to prepare the medication. And first inspect the bottles, make sure that there is no abnormalities, that there is not yellowing or anything unusual about the prescription. Make sure that caps are on. It's good to tap the medication to make sure that they are freely moving. They've been taken out of the fridge about an hour ago. Medication should be refrigerated if it's stored for a long time, but it can be out of the box in the room temperature for up to a week. So if you receive the medication in the ice box and you think you will administer it within a week, it's not really necessary to have it in the fridge. So those look pretty normal. I'm gonna open the vials, clean the tops where the alcohol goes. So I'm gonna use this syringe for preparing the medication, and I'm gonna use this small needle, 1-inch needle. And it's a lower needle, so pretty straightforward. So I'm gonna first take diluent from the diluent vial. We're gonna take 3.4 milliliters. So I usually take everything that is in the bottle, tap it, and get 3.4. I'm gonna inject it to the bottle with the microspheres. I'm gonna shake it for about a minute to make sure that it's evenly distributed. Sometimes you can use an automatic electric shaker, but it's not really necessary. I'm gonna clean it again. And now we're gonna draw the content of the vial into the syringe. It's relatively thick, so it's going slow. Again, we have a chance to inspect for any abnormalities, any clamps. Yes, I put everything. And I'm gonna now prepare the needle. So for this patient, for most patients, it's probably preferable to have a longer needles to make sure that the medication reaches into the muscle. If medication gets administered to subcutaneous tissue, most of the adverse reactions are related to the fact that it's not in the muscle. So I'm gonna unscrew this small needle, put on the big needle again. I'm gonna screw it here, and now we're gonna ask the patient to come to the room. So circular motion, clean up the area. One more time. So we need to administer 4 cc of the medication. And it's good to relax the muscle before the injection with a smooth motion, check for the blood draw, and gradually inject the medication. How are you doing?
All right.
Okay? Okay. All right?
Yeah.
So we're gonna massage the muscle a little bit so the medication gets.
So I'm gonna stop there. He's like super fast. He just like jabs it in. It's impressive how fast he is. But I think a couple of key points there to just talk through. So the first is, we want to get the shot right? And we have to get into that muscle. And so if patients are like, why is your needle this big? Being able to explain to them, we really need to get into the muscle to be effective and to make sure that we are minimizing the risk of other adverse effects. I think the second thing to do is the positioning is really important, right? So the client needs to be as comfortable as possible. That's going to help relax and get that the needle where it needs to go. I think you can advise your patients or your clients, to talk with your doctor and say, this is an uncomfortable position. Is there another that I can shift into to make it a little bit more comfortable? What they were meaning by alternating is, for that first month, it would be, for this patient, it would be on the left side. For the next month, it would be on the right side. And by the time they're getting that shot back on the left side, there of course shouldn't be any of the medication, the depot left over there. Let me go ahead and get my slides back up and we'll go from there. So as promised, I'm going to talk a little bit now about keeping people in treatment who are on extended release naltrexone. So I'm starting at a slightly weird place here, but this is important. So a couple of years back, the FDA put out a warning letter to the maker of extended release naltrexone for some of the ads that they were putting out. So the ads were saying a lot of things that were true, and that it can be an effective medication for opioid use disorder, but it wasn't adequately disclosing the significant risks that we went over earlier about overdose when somebody stops taking extended release naltrexone. And so the FDA basically said, you can't keep on putting out these ads that are telling clients that it's only a positive thing. There are drawbacks to that, and you need to be honest about that. So it's important to acknowledge that some of that narrative that's out there about how this is only a positive thing is coming from the drug manufacturers, and I think we just need to be open and honest about that. So when you actually ask clients, and this was from a qualitative study, when you actually ask them, hey, why do you stop using extended release naltrexone? There's a few themes that sort of emerge. So there's one around this sort of idea of body purity, I would say. So this idea of I know how I get when I put anything in my body, or I'd rather not have anything in my system. And that can come out of stigmatized views towards medication that we in society sometimes hold, and that includes medications for depression, right? Which one of the clients in this study actually spoke specifically about. I don't want antidepressants. I don't want anything in my body. There can be external pressure or lack thereof. And what I mean by that is because many folks who are getting naltrexone are getting that as part of, say, early release program coming out of prison or probation and parole settings. There's this very big carrot of if you are continuing in treatment while you're and getting the extended release naltrexone, you might have the time that you're in parole shortened, or you might have your jail time shortened. And who wouldn't say no? Who wouldn't say yes to that proposition? But when you remove that external pressure or that external motivation, then you're left with: is this client still a little bit ambivalent about whether they want to continue or not? And that's why exploring that motivation up front can be really helpful. Slips or relapse. So one client sort of was associating the fact that they had some slips on naltrexone and said, that to me was proof that the medication wasn't really working. And that's not always the case. It may be that there's other things that are contributing to ongoing urges or cravings that are reversible. Those might be mood issues or sleep issues or other health issues or social issues that can be addressed. And then a really common one, again, was payment issues. So when somebody is released from a jail setting, they often their insurance has lapsed during that time, right? And so getting them back insured can be a critical step to making sure that they can continue the extended release naltrexone if it's helping them. What can we do to improve retention? I think there's a couple important points. So the first one is education, right? So we have to review those concerns about return to use and folks' overdose risk following cessation of extended release naltrexone. A big way of exploring motivation is through motivational interviewing. So trying to understand those personal drives, those personal motivations to continue into long-term recovery and remission of their opioid use disorder. There's been several studies looking at contingency management to try to keep folks in treatment on extended release naltrexone. As a reminder, contingency management is the idea of, with each successive negative urine drug screen or step towards long-term recovery, there's associated reward in a program. So that might be something as simple as a gift card or Uber rides, or it might be something more extensive, like trying to get into housing programs, or like we talked about, sort of probation and parole. The specific things that they looked at in this study was smaller sort of monetary rewards associated with negative urines. And they found that folks stayed in treatment an average of 7.4 weeks compared to 5.6 weeks with that added contingency management. We might, scoff a little bit at that and say, what is an extra 2 weeks or so? But that might actually be another shot for them and actually provide some protection for an additional month. In another study, they found that percentage of participants receiving the scheduled injections doubled when contingency management was part of what was offered. There's a small form of contingency management built into some of our digital therapeutics, like the Reset app. And so that can certainly be utilized if insurance is covering that as well. And then treatment of co-occurring mental and physical health issues, right? Those are significant barriers to staying on the naltrexone. We want to make sure that we're addressing those with evidence-based therapies. So for the last few minutes here, I want to go over a case, answer a few questions, and discuss sort of next steps. Before I do that, I'm just checking the chat here. Oh, so good question, Natalie. So Natalie asks, I have an acquaintance that uses Vivitrol and gets injections in the stomach. Is that routine? I have always given it to clients in the hip. So the hip is absolutely sort of the number one, that gluteal muscle is absolutely the number one place we want to go. There's certainly increased risk when the target, so how much actual muscle is there, shrinks, right? Because there's now increased risk that's going to be in the sub-Q space or the adipose space. So while there's unlikely to be significant clinical effects of that Vivitrol going into the muscle in the stomach versus the muscle around the hip, it's just around the procedural time that I would have a little bit concerned. But with an expert who can make sure that it's going to where it needs to be, that can be helpful. Okay. Case time. So Mr. D is a 26-year-old student with severe opioid use disorder, complicated by a recent non-fatal overdose. And he comes in today and shares that he is using intranasal heroin and / fentanyl in a binge pattern. So usually on the weekends when he's out with friends. But more recently, he's struggled with some withdrawal symptoms during the week and has begun to use small amounts of fentanyl or heroin daily intranasally. He doesn't use any other substances. He states that his job does some random urine tests, and he's a little bit worried that he'll fail a test if he doesn't stop using. He has a close friend who's done well on extended release naltrexone and asks if he can start that today. So any initial sort of concerns or reactions to hearing this case? Maybe I'll be a little bit more specific in a first question. What do we think about that last statement, that he had a close friend who's used extended release naltrexone and it works for him, and he's wondering if he can start the medication today? What do we think about that statement? Yeah, so John, good. So when was the last time they actually used heroin or fentanyl? Yeah, great, Samantha. If he hasn't detoxed, he wouldn't be able to start today. So, it speaks to me of maybe some misconceptions that he might have about naltrexone. So it might be useful to even start there of, what else have you heard about naltrexone, right? It sounds like your friend has done well on it. I just wanted to see what you think. Good, Amy. So I think there's going to need to be some MI going down to gather more info on the entire scenario and see if it's the right fit. But yes, trying to pinpoint, when was the last time you used? Certainly trying to get that urine drug screen to see what he's using and confirm that it is indeed fentanyl. But more importantly, trying to address maybe some of those misconceptions that you might have about the medication and why it might work. I think equally important, you can explore whether, yep. So Lisa brings us up, provide him with all options. Making sure that he's aware of, if the priority is trying to control cravings and withdrawal, naltrexone is not going to do that right now. But buprenorphine and methadone might be good options. So let's talk about that. Okay. What do you guys think about this patient as a candidate for extended release naltrexone? Let's say that he's open to going through maybe an inpatient detox and then starting naltrexone after that. What do we think about him being on the extended release naltrexone? Pros or cons? Yes. Lisa, I think great point about work, right? So he sort of stated that work is a driver behind coming in today is worried about potentially getting fired. And so we might want to explore, where his finances are and where that sort of concern is coming from. But equally important, as Tom is pointing out, is, if his work saw methadone or Suboxone in his urine, or buprenorphine, sorry, what does he think their reaction would be? Is there, does he know of what the rules and regulations are around treatment of chronic mental illness at his facility, as what medications can be used, what can't be used? Yep. And so John mentioned sort of this affinity group. So he might have this other friend who's also getting it. And we didn't talk about that as a retention tool, but I do think that that's helpful, right? Of getting that positive social feedback of, great job, I'm doing this, you're doing this, we're doing this together. Let's make sure that we keep each other honest and are following up at the same time to get subsequent shots. So that can certainly be a plus. I think the biggest concern that I have is this recent overdose, right? He is at elevated risk for another overdose. And I don't have a great understanding of what potentially drove that overdose. It might be this sort of binge pattern where he's losing a little bit of tolerance during the week, but he's actually been escalating use during the week. So I think my biggest concern with sort of jumping to the extended release naltrexone is I know that at that 90-day mark that it underperforms compared to buprenorphine and methadone in terms of keeping this person alive and giving them the best chance at long-term recovery. But I have to acknowledge that there's a lot of barriers to those medications as well, which we've gone over in a lot of our other KY Open sessions. So with that, I just want to leave you with the message of this is not easy. This is complicated. A lot of the studies that I reviewed were in very controlled settings and not really in the real world where we practice. Many of them were 5, 6, or more years ago. And so fentanyl prevalence was not what it was now, which complicates getting folks through that withdrawal period. And so while I think it's critical to make sure that patients who are seeking treatment and wanting to get started on extended release naltrexone, we're doing everything possible to make that happen for them, because that motivation is there, and we want to make sure that we're responsive to individual patient needs. We have to have our eyes open about the drawbacks, about the concerns, and patients deserve that, right? I think the story of extended release naltrexone, if I were to sum it up, is that we need to, as a society, be more responsive to patient concerns over our own convenience, right? So yes, it might be easier in the long run for somebody to get a shot a month, but we need to be hyper attuned to why they're seeking treatment, what's important to them, and be adaptable in terms of what we're offering. With that, I'll take any questions. And I apologize for my weird camera angle. I'm using a borrowed laptop, so if you just got a shot of my neck most of the time, I am sorry.
Dr. Oller, this is probably a little bit on another topic, but draws into this. I have a really hard time in my brain, Suboxone is buprenorphine and naloxone together, and then this is just naltrexone. But does the naloxone and the Suboxone just act kind of like the naltrexone does? I mean, is it doing, and that might be way too complicated, but.
Oh my gosh, Amy, I'm so glad you brought this up, right? Because I do hear this a lot, right? So think of it this way. So the naloxone is not doing anything in the Suboxone other than if somebody is trying to inject the Suboxone, it's going to be active, right? So when taken sublingually, it's not that there's no naloxone that's absorbed, but it's such a small amount that's not doing anything. Okay. It's only there to act as a deterrent from injection use of buprenorphine products. That's different than the naltrexone, where our goal is to actually get it to a high enough concentration that's over all those opioid receptors and sitting snugly on them so that other opioids coming in can't act.
Okay, I didn't know that. See, I just always assumed even if it was taken sublingually that like naloxone was still somehow going to bind to some of those receptors and whatever, but it's just more of a deterrent to not intravenously inject the buprenorphine.
You got it.
Okay. And is Subutex just straight buprenorphine?
Yes.
Okay. Okay. Thanks. I know that was a little cloudy, but I just, those words,
That's
naloxone
perfect.
and naltrexone, sometimes get like, I think for lay people like me, almost get interchangeably, and they're not the same thing at all. So.
Right. Awesome. Well, I am happy to take other questions. I put my email in the chat in case you guys had some personal questions that you wanted to ask that didn't feel ready to jump into the group and ask. And then we'll have plenty of time next week to go over some scenarios and dive a little bit deeper into pros and cons of naltrexone and how best to make sure that we're getting people treatment and keeping them in treatment.